Critical Thinking and Coding Tips for Chapter 11. Okay, our first critical thinking question. What are the challenges associated with coding anemia? And our answer. There is not always precise documentation when it comes to classifying anemias. When the physician documents an unspecified anemia, the coder should review the medical record to determine if more information can be located in the laboratory or pathology report, or perhaps in a consult by a hematology physician, because they are the experts in blood disorders. It's likely that they will be more specific in their documentation of anemias. Also, postoperative anemia does not code to acute blood loss anemia. To code to acute blood loss anemia, it would have to be documented as such. A code should never be assigned on the basis of a laboratory and/or pathology report alone. These findings must be correlated in the medical record by the physician. If not, a query would be appropriate. Our next critical thinking question: what is pancytopenia and how is it different from anemia? How is it coded? And our answer: pancytopenia is a type of anemia that affects all elements of the blood. Therefore, the patient has anemia, which is red cell deficiency, neutropenia, which is white cell deficiency, and thrombocytopenia, which is platelet deficiency. Now, if pancytopenia is documented along with anemia, neutropenia, and/or thrombocytopenia, only code 284.19 pancytopenia, because the anemia, neutropenia, and thrombocytopenia are inclusive components of the pancytopenia and should not be coded separately. There is an exception, however. When neutropenic fever is present, it's acceptable to code the neutropenic fever separately. And our final critical thinking question: when should hemorrhagic disorder due to intrinsic circulating anticoagulants 286.5 be coded? Does this occur when a patient is on Coumadin therapy? And our answer: this is one of the codes in this chapter that seems to give coders some problems. Because it is a CC, it's important to know when, and more importantly when not to code this disorder, because it might be seen as upcoding. This code of 286.5 is rarely used. The condition results from the presence of circulating anticoagulants in the blood and is usually inherent or intrinsic in the blood. It's not typically a result of a patient being on long-term anticoagulant therapy, so caution should be taken when assigning this code. In a case in which a patient is on long-term anticoagulant therapy, assign a code for the condition relating to the hemorrhage, along with an E code for the responsible medication. Only code 286.5 if the physician clearly documents a diagnosis of hemorrhagic disorder due to circulating anticoagulants. Now, here are some coding tips for this chapter. There are situations that might make a coder look for a diagnosis of anemia, coagulation disorder, or white blood cell disorders. Examples would be: 1. A patient is admitted for a GI bleed. You might want to check laboratory results for low hemoglobin and/or hematocrit for blood loss anemia. Next, a patient is admitted with weakness and pallor and has a history of untreated cancer. Check laboratory work for secondary anemia due to neoplasm. And last, an African American female is admitted to the hospital with severe chest pain and a history of sickle cell trait. You want to review the record for a diagnosis of sickle cell anemia with crisis. Next, we have common procedures done for blood disorders. The first one is a transfusion, the induction of blood components into the bloodstream. The most common types of transfusions are red blood cells, plasma, and platelets. Now, an autologous transfusion is one in which patients donate their own blood to be used in case they need a transfusion. Now we're continuing on with common procedures done for blood disorders. First, we have the apheresis. This is where blood is withdrawn from a donor. A part of the blood is separated and retained, and the remainder is retransfused into the donor. Next, we have a bone marrow biopsy, which is the removal and examination of bone marrow used to diagnose types of anemia, sickle cell deficiencies or cell deficiencies, and leukemia. And last, we have bone marrow and or stem cell transplant. These are used to treat certain leukemias and cancers. The patient receives heavy doses of chemotherapy and or radiation before the transplant. The bone marrow or stem cells are then infused into the patient. Now, one abnormal laboratory finding is irrelevant when it comes to classification. Guidelines are: one abnormal finding that is clinically correlated in the documentation and treated during the stay can certainly be coded, as it meets the definition as a secondary diagnosis. However, two or three slightly abnormal findings in a row could be normal for a particular patient and not addressed by the documentation or treated, and therefore should not be coded, unless it meets the definition of secondary diagnosis. And finally, review the exclude notes in this chapter. Notice how if the patient is a newborn, the book refers you to the congenital anomalies chapter. Other blood disorders that are a result of malignant neoplasm can be found in the neoplasms chapter. It's important for a coder to become familiar with the exclude notes in each chapter of ICD-9 CM.